So what we're here to talk about today, I'll tell you a little bit about myself, but we're going to do some introductions as a group as well. But we're really wanting to talk about some issues that in my mind have always been important, and I think to all of us are important. The role of culture and health, and how those things intersect and intertwine, and you know just as importantly, how do we think about that in developing tools to promote health equity and to inform public health in different ways? So my name is Annie Belcourt. I am a professor here at the University of Montana in public health. Well, it's the School of Public Health and Community Science. I always mess up the title a little bit, and also pharmacy. But most of my work is definitely within the realm of public health. My doctoral training is in clinical psychology. So definitely a bias of mine is towards, behavioral health and mental health, and, but also culture. So I grew up on the Blackfeet Reservation. I am an enrolled member of the 3 affiliated tribes, the Mandan, Hidatsa, and Arikara in North Dakota, but I also am a descendant of Blackfeet and Chippewa. So there you go. Very multicultural already, right? As we talk about multicultural, and of course, like the Belcourt, there's some French somewhere. So those are some of my kind of background information, and I'll talk with you a little bit about some of the work that I've done in this area. But again, I want to kind of really encourage all of us to be part of this discussion as we have this 3-part series. The first session today will be focused on more kind of establishing some foundational kind of ideas, and we'll review a video, and we'll talk about how aspects of that video pertain to Montana and Montana populations and things. So we'll do that, but we'll have interactive small breakout sessions in the day, and we'll talk about how some of these different factors translate to tools that we might be able to use, and to brainstorm some ideas for that. I also want to get feedback for what people would like to see covered in the next 2 weeks of this workshop. So part of my idea is to really have you all, have that ability to, be curious and think about the things that they'd like to have us all discuss and consider. So in that light, I did send out that little link to some of the implicit bias tests, or there's sort of surveys that have been developed by people at Harvard and other institutions. And they're really very simple, but they're just ideas about thinking about how we examine culture, how do we think about what are the things that we assume as individuals. So being a psychologist, like, one of the things I know is that we all carry around assumptions, and it's a way that we survive every day, right? In terms of, I assume I shouldn't walk in front of a car. I assume that I should, look both ways when I cross the street. I assume I should wear a mask right now. Those sorts of assumptions that help to protect us, from some of the things that, could potentially pose risk factors. So, so this is kind of like some of our discussion is to think about what are some of the things that, are the lens that we look through, and how can we work with those things to help us, become more effective, engaging, and helpful in the work that we do in public health. So that's kind of the the hope for this workshop, is to have it be very, very interactive. Uh-oh. Now if I can learn how to advance my slides. Okay, so this is the agenda for today. As you notice, I posted this into the chat. So if you open the chat, you can go back and take a look at this as well throughout the day. And I do want to also mention that these slides will all be shared with you. I didn't want to share them prior to the talk today, but because I wanted to kind of have it be fresh and whatnot. But we will be sharing these after the fact. And but the agenda first is we're going to do some introductions. So, and the idea there is, depending on how many people we have today, is to be pretty brief. But I do think it's really important that we get a sense of who we are as a group, the diversity that's within our group, the interactive learning goals that we may have individually or as a group. What are the resources that we may be able to share with others, and how we can kind of think about best practices moving forward. So that'll be the first thing that we'll do. I'm hoping, depending on things, we can get that through that, you know, in a good, you know, concise way, but very friendly and welcoming way. But really happy to have you all joining us today. Is really going to be, I think, an exciting discussion. We're going to watch a video that talks about health disparities more widely within the United States. And it's by a colleague who is a pioneer in the area of racial inequalities and thinking about not only racial inequalities, but inequalities across the US and how those impact health in a global way. And then we'll talk, we'll have a break and actually we're gonna have a discussion about that video, because I think you'll have some things that you'll probably, you know, it'll bring up some ideas and discussion points. And then we'll have a brief break, and then we'll talk about Montana disparities. So sort of how that video translates to Montana, and how do we think about some of the things that we face within our state. We'll have some small group discussions, and we'll have that through breakout rooms in Zoom, and Emily will help me with that, thankfully, and why different inequalities persist, and the initial ideas and kind of brainstorming on tool development. So we'll have that discussion later this afternoon. And then we'll gather back together to talk about like reporting back to the larger group on those ideas and how we can move forward in kind of innovative ways. So that's kind of basically today in a nutshell. You'll have a homework assignment, which is going to be, you know, no longer than an hour, but just basically we'll go through the details of that at the end of the session today. And you should have gotten some articles. I apologize, like I didn't want to seem like I'm all about me or anything, but I am co-author on those different articles. And part of that is just because I am working remotely, like many of us right now, and it's a little difficult to get access to university articles right now. So I had to kind of go from what I had on file. So, but they're very much, you know, related to our topic. So I hope that you find them interesting and a good resource for the future. Any questions before we get going? Any issues with, like, you can hear me and everything and see me? And okay, great. Right. So what I'd like to do is, it says 5 minutes. I don't think we can do 5 minutes just in terms of logistics and things, but if you could limit, you know, your introductions to about 2 minutes or so. And then here's some ideas for you to think about. You know, first, just tell us about yourself, you know, basics and who you are, what you do, what brought you to this workshop, what are your hopes with regard to public health and equity for Montana? What are the resources you'd like to share with attendees at the workshop? And are there tools or approaches that you found to be particularly helpful in your work? And if you don't get through this in introductions, I think this will come across, and we'll revisit this during our subsequent meetings as well. Because, you know, the hope is that this workshop will help to kind of spur some ideas as to what things may be helpful. So I'm not sure how best to do this, but let me exit out of share screen for a second. Or maybe I should keep that up. So do we have any volunteers to go first in introductions?
Sure.
I will if, oh, somebody else did.
I'll go first. I have to pop off. I have a boss who is making me jump in and off. So I'm Olivia Ryuta. I'm the Outreach, Engagement, and Population Health Manager at the Montana Primary Care Association. And so I found this, I'm also pretending that I'm a graduate student in public health at the U. So I got it from both sides, my professional and my personal. So I am particularly interested in this conversation because I think it fits in with a lot of the work that we are doing and can be doing better within community health centers, right? I work for the association that provides training and technical assistance and support for both federally qualified community health centers and now 3 out of the 4 urban Indian health centers are our members also. And so we are having kind of our own internal work at the Primary Care Association about equity, diversity, and inclusion. And so we've been trying to kind of dig in to this work organizationally and think about what does it mean for us? What does it mean to support partners? And so I'm just really excited about tools and ideas and things that I can bring back to that work. And I think, yeah, and I do a lot of work right now. My life is consumed around outreach and enrollment in health insurance coverage programs. And so I think my hope is to always bring the disparities in coverage and access to care, bring this work into that work, because I think it will allow us to do it better. So I'm really excited about this space, and thank you.
Welcome, welcome, thank you. All right.
All right, I'll go next. My name is Kathy Moore. I'm the Environmental Division Administrator for Lewis and Clark Public Health. I have Zoom burnout really bad, so mostly I'm going to keep my video off because I'm just tired of it. I came to this workshop because I really have an interest in the topic. I don't feel like I know very much about it, but I want to bring it into the work that I do every day at the health department. And I want to just do a reality check and make sure that I'm doing everything I can for the residents of my community. And also in my private life, I want to be sure that I'm doing what I can do there as well. So I don't really have resources or tools, but I'm looking forward to this workshop. And I want to thank you all for putting it on.
Great, thank you and welcome.
I'll go ahead and jump in next. So I don't have the video on because of Zoom burnout, but my name is Lani Paulson. I work for the Rocky Mountain Tribal Leaders Council Epidemiology Center. We're often referred to as RMTLC or RIMTech. So if you've ever heard those, but we are the Tribal Epidemiology Center for the Rocky Mountain region. So that would be all of the tribal nations in Montana and Wyoming. The reason why I'm interested in this topic is even though I grew up in Montana and I'm familiar with, some of like the cultural like competencies, there's the importance for always being like willing to learn and to get new insights and ideas. My boss actually just did a cultural competency for working with American Indian populations for new staff members, and she's out of town right now, but I don't think she would mind me sharing that presentation, and it just kind of goes over what we do and things to keep in mind with the different tribal nations in Montana and Wyoming. So
Wonderful. Yeah, if you wouldn't mind sharing, that would be wonderful. Thank you.
yeah, she gets back on the 24th. So once I get an okay from her, I'll send that on. So
Thank you very much.
thanks.
And welcome.
Minnie Bailey? What about Laura Bird?
Hello, my name is Laura Bird. I'm the eligibility specialist at All Nations Health Center, and I help connect people with coverage with Medicaid, the Marketplace, Medicare. I'm very interested in this workshop and the topics and what I can learn from it, and also connecting with other individuals in the community as well. And resources I can bring are my knowledge in working with healthcare and the indigenous population of Missoula. And tools I feel that have been helpful in my work is just connecting with other individuals and sharing ideas and getting feedback from the community are very helpful in my work. So thank you. Thank you for having me.
Thanks and welcome, Laura. It's good to have you here.
Awesome. Can we hear from Amanda?
Yes, hello. I am Amanda Trin. I work for the Weld County Health Department. I'm in Colorado, actually, so I'm not a Montana person, but I just like to take a lot of trainings to increase my knowledge and things like that. Health equity is just a thing that has really spoken to my heart lately. I think also being a person who identifies not white, it is definitely something I want to pursue in my life personally as well, I would say. So I'm just trying to learn all that I can to really bring health equity into the playbook here in Weld County or in Colorado, and basically just in public health in general. So I'm just trying to learn as much as I can. And really find tangible tools to take away, because I feel like I've been in a lot of trainings and we just talk. And so I don't know what to do about it. So that's where I'm hoping to go. And I don't have very many resources, but hopefully the other trainings I've been in with some knowledge are resources to share, and hoping to learn a lot from everybody. Thank you.
Welcome.
Awesome. What about, let's see, I think Bailey was typing in the chat box. She says she is new to public health and serving as an AmeriCorps with DPHHS. Grew up in Idaho, but feels very ignorant to most of these issues and hopes to expand her knowledge. So that is her intro. And now if Casey, and forgive me if you already spoke because I did not take note of all the names, but Casey, are you there?
I don't see any other Casey, so I assume that that is me. My name is Casey Pierce. I also live in Colorado. I work for the Weld County Health Department. I am a facilitator for the Carbon Valley Communities That Care Coalition, which is a coalition that really works on youth substance use prevention within the Carbon Valley area. Montana has a special place in my heart. I have multiple family members that live in Livingston, and we frequently are there in the summertime. So this excites me when I get to see a lot of Montana people. What brought me to this workshop? So on a personal level, I am the mother of 2 young sons, and I know that the things that I teach them throughout their life and expose them to and instill in them are going to affect the way that they are as people when they become adults. And I want to make sure that I give them every opportunity and instill in them really beliefs and advocacy skills, and just to make them better people. And so I have to practice that myself in order to do that. On a professional level, I have found it in my heart that really health equity is something that I really need to be focusing on a little more as I've begun to work with more diverse groups of people. And my hopes in these courses or these trainings is to expand upon that and learn from people from other areas and what their experiences have been, and to just make sure that I am not making more ouch in my life or in other people's lives as a result of my thoughts and beliefs. What resources would I like to share? I'm not sure at this time. I've been to a lot of trainings with Amanda. I have a lot of expertise and work with youth, and so that's something I think that I bring to the table, but I'm just here to learn.
Awesome.
Awesome. Thank you.
Thank you. Do we have Deshane?
Yes, Deshane is here, and Deshane does not do heat very well, so I'm here to cut off. So I'm going to keep my video off for a bit, because I'm in what my coworkers consider to be air conditioning that I don't, and I have the fan going and a cutoff and I'm still hot. So, but yeah, so Deshane Barnett, director of All Nations Health Center. I encourage several of my staff to sign up for these, so you'll see them here today also. And, you know, so I'm completing my PhD in public health. Annie's actually my dissertation chair. And so I know that I've talked to her about this one tool that I'm going to mention, but what my hopes are is that the tools that we develop, whether it's for research or program administration, because that feeds into research, it's all data, that we move toward, you know, I work in American Indian Health, so I focus, you know, on the Native community. And for basically my entire life and before that, the focus has always been, what are the deficits? What is wrong in Indian country? What needs to be fixed? What is bad? What is broken? And what I want to see is us to move to a strengths-based approach where we find what works well. What are our strengths? What are our inherent assets? What are our, you know, interpersonal assets, community assets, and how do we use those then to increase and improve the health status of our community? And so I think, you know, nowadays a lot of folks in public health are very familiar with ACEs, adverse childhood experiences. And, you know, I get really frustrated when, you know, people want to use that as a tool within our Native community. We know within the Native American community that 90% plus of our community will have 2 or more ACE scores. There's not even any reason where most of us are going to be at 3 or above. So there's not even any real reason to do it. And then there is a new approach for PCEs, positive childhood experiences. And so the state of Wisconsin, when they did their BRFIS a few years ago, they were the first one to use the positive childhood experiences as part of their BRFIS. And I really want to advocate for that approach here in Missoula, in Montana. So for Missoula, All Nations Health Center will be doing a community health needs assessment. We're hoping to get our notification of funding from NIH very soon. And so we'll be doing that. And we are going to incorporate the positive childhood experience measures into that survey. And I would love to see more of that type of strengths-based tools out there to support both the research and the program administration. So, and I'm looking forward to it. So thanks everyone.
Welcome, Deshane. Yeah, thanks for being here. I hear you. I don't have AC here.
I'm not good in the heat either. Thank you very much. What about Emma?
Hi everyone, my name is Emma Spalding. I am based in Denver as well, so have a couple folks on the call. I work for NASPA, which is Student Administrators in Higher Education, specifically on a grant, our Healthy Colleges Montana Coalition. So with that work with 17 institutions, higher education institutions in the state of Montana, which serve multiple campus locations. So it's most institutions in the state, not everyone, not all of them. So part of the reason I love being on Montana Public Health Things is that there's sometimes connections to those other institutions. And we are all, our grant work is to help health of college students. Specifically, we're funded for chronic disease prevention. And so any way that we can continue to be more equitable in the work that we do with the diverse institutions and student populations on there is great. So I'm happy to share any resources that we as a coalition have if you all are working with college populations at all. But I always like to hear what different counties and institutions within the state of Montana are doing and ways that we can work with you all with those local institutions.
Awesome. Thank you, Emma. Also, I was born in Denver, so all the Coloradans, you hold a warm, fuzzy place for me.
Love it.
Yeah, I worked in Colorado for 5 years too, so yeah.
We love Colorado.
Yeah.
All righty. What about Erica?
Hi, everyone. My name is Erica Rubino, and I am the Registered Dietitian and Wellness Care Coordinator for All Nations Health Center. Deshane is my boss, and that's actually how I found out about this training. Health equity has been a big part of me as a dietitian and all the work I've done. I'm pretty new to the organization. I've only been here for about 2 months, and I'm really excited to be here to learn more about health disparities and the impact of culture as I'm building a nutrition program and as I'm building programming to make sure that it is culturally relevant and I am helping our population. I'm originally from Brazil, so I definitely think that brings some to it as well. And my previous job was working in another federally qualified health center with farm workers. And so again, health equity has just been just very predominant in my career. I don't really have too many resources right now. I'm looking for resources as being new here at the All Nations Health Center. So I'm really excited to hear and learn.
Excellent.
Welcome.
What about Erin next?
Hi all, really glad to be here also. I'm Erin Austin. I currently work as the Assistant Director at Tamarack Grief Resource Center, which is headquartered in Missoula, and we have offices in Kalispell and Browning, and work with communities across Western Montana and right now the state, as we're all virtual. I come to this workshop really, gosh, eager to learn, eager to build relationships, grateful to have this opportunity. Thank you, Dr. Belcourt, and all of you for making this possible. I would echo a lot of what's been said. Here for some introspection work and really curious about building my own awareness around health equity and how I am a part of systems that perpetuate inequalities and how I work against those, and then am in a position of influence in my job where I would like to bring this work in as well. I see grief and trauma and loss as a big part of our health systems, mental health certainly, and then have a bit of a background in working with our food and farming systems, also in environmental justice and environmental health. So yeah, really thrilled to be here. Thank you.
Welcome. Thank you.
Oh, awesome. Can we hear from Faith next?
Yeah, here I am. Can you, potentially, I think I'm here. You guys can hear me. I can't see myself. But, my name is Faith Price, and I'm the Community Prevention Coordinator at the All Nations Health Center, along with Laura and Deshane and Erica. I just started there back beginning of June, and I'm also a doctoral student in prevention science through Washington State University, which is where I was prior to coming home to Montana. I'm from Montana originally. But as part of my program, I took a course on health and inequality. It was one of the favorite classes of all of grad school, and one I learned the most in. Learned about the social determinants of health, and I just found it so fascinating how our society and communities shape our health. So that's what I was excited to come to this workshop and talk more about those type of topics. And I'm passionate about improving the health of our Native youth, improving wellness for our tribal communities. And that's most of my work experience has been in tribal communities. And let's see, any tools resources to share, I would say, if anyone's interested in taking that health inequality course, it's for credit. It's being offered this spring, and WSU is completely online, so if you need a good class, you could potentially get in it. That's all from me.
Awesome.
Good plug.
Welcome, Faith. And Faith also felt, she is legendary in her work, but also she comes from a legacy of that. And her father is George Price, who is a beloved, professor here at the university for many years. So yeah, we're welcome, Faith.
What about Janet?
Hi, I'm Janet Suka, and I am the liaison for the state between the tribal nations here in Montana and the state for tobacco prevention and commercial tobacco prevention. And so I've had the fortune of working in this field, at least in this job, for 10 years, and sort of in the field of commercial tobacco prevention for 20. And we still have some of the same issues that we've had for 20 years, but I really have been excited to be a part of this team of tribal members who we're working at really trying to find those positive ways of healing rather than always looking at the deficit. So thank you, Deshane, for mentioning that. I've worked with Dana Kingfisher from the All Nations Health Center, and Deshane's been a great advocate for a lot of the work we do. Dana's amazing in that. I have lived on the Flathead Reservation for 30 years, and I really find for me, it's just been so exciting and enriching in working and learning more and more about the tribal communities here in the state of Montana. And I feel like I've been very privileged and in my life for sure, but also fortunate to build relationships around the state and get to see some health inequity right there, and try to work towards making, finding better ways of healing at a societal level, as well as just working on the commercial tobacco prevention work. I was just on another webinar this morning, and I'm in and out of a CDC national webinar or conference that we're doing right now. But, you know, it was talking about culture is medicine and looking at that with tobacco rather than just commercial tobacco being a harm, which we all know it is. So really looking at culture. My background in my BA was in social anthropology, so I've been really interested in that for many years. And so I've heard a lot about Annie Belcourt, and I've really wanted to hear her speak. So that's part of the reason why I took this class. I don't have any particular tool for sharing. I've got a lot of information about traditional tobacco and commercial tobacco, but one of the things that has been we've been tasked with at the state from CDC is to work on disparities and to really have a 5-year strategic plan on creating a better way of reaching into the populations that have such high use rates, which of course in Montana is the American Indian population. And we're in the beginning phases of that. Most of that work I hope will be done with the group of commercial tobacco prevention specialists from around the state who work in the local areas with their tribes. But what I find for me is I just want to be a better liaison to hear what is happening at a local level, what are the needs, what are the ways of creating change that's positive for them at a local level, and how can I, as a state employee, help make that happen? Because often, as we all know, the state will come in with, we've got this, this, and this for you, and let's go for it. But what I hope to bring to my job is that the people in the field really have the answers, and whatever I can do to make that happen is really what my role is in capacity to do the work that I do in my job. So I'm excited. And again, I think somebody else had mentioned it, I'm going to be called in and out. And so you may see me at my chair, you may not, but I am excited to be a part of this as much as possible. So thank you.
Awesome. Cool. Yeah. Talk about multitasking with all of your
webinars and whatnot. No, I was like, God, well, as I look through all the pictures, I think I might be the oldest person here. So that's part of the reason why you can say things like 30 years and 40 and 50 years ago, that kind of stuff. So anyways, it's nice to meet everybody.
Awesome. Thank you so much. What about Jen Robinson?
Hi, everybody. I am the tobacco specialist in Anaconda, and I'm hoping to work with Janet a little bit more about our tobacco for our tribals here in Deer Lodge County. I've only been with the public health for just a few months, so just understanding more of our youth and our Native Americans and everything, so I'm excited about this. So that's about what I have. Sorry, guys.
Oh, welcome.
Sounds great. Thank you. Let's see, what do we got? Kathy Moore?
Yeah, I couldn't find my thing. I already introduced myself.
Oh, that's okay. I knew.
But here I am again.
Glad you're still there.
I'm here, just can't find my mute button.
Okay, let's see. And I think we've got Lanny, we already heard from, I believe.
Yes, I already introduced myself.
Excellent. And we had Laura. What about Leanne?
Hello, I'm here. So my name is Leanne Mortensen. I'm from Livingston Healthcare in Livingston, Montana. So we're just starting a program for our chronic disease patients to try to promote and be proactive with their care. So I just really was trying to just gather a bunch of information and knowledge from, I'm taking these 3 classes. I took your last class that you had on the 6th, I believe, of August. And so we're doing a flu clinic based off of that. That was my need I found. So we're meeting tomorrow to see how we can immunize our county with influenza, because only 29% of our population had been vaccinated last year, which is pretty low compared to the United States and Montana's average. So I grew up actually in Havre, right next to Rocky Boy Indian Reservation. So I knew I went to school with a lot of those people and have been on the reservation my whole childhood. So I'm also a respiratory therapist and an RN, so the tobacco is very important to me. So yeah, we're just starting this program, so I'm just trying to get a bunch of knowledge. I don't really have any resources. I am in contact with our local Park County Health Department a lot. One of our physicians works there as the director now that I worked with, one of our internal medicine physicians. So it's really nice having all of those resources and us being able to talk, you know, anytime I need anything, they are there for us. So I'm just excited to learn with you guys.
Yay! Yay. Awesome. Yay! Thank you. What about Nancy Hubbins?
Hi, everybody. I'm Nancy Hubbins. I'm the Suicide Prevention Coordinator at the Missoula City County Health Department. Hi, Annie. I'm here because I've been in my position for a couple years now, and I co-chair the Project Tomorrow Montana Suicide Prevention Coalition. Basically, I'm here because I don't know what I don't know, and I don't know what I'm doing to create, you know, welcoming spaces or what I'm doing to turn people off from the work we do in education and prevention. And so I'm here to listen and hopefully improve the work that I do and broaden the coalition and the opportunities for people to learn how they can intervene in mental health crises. So really excited to be here.
Wonderful, welcome.
Thank you. And we heard from Olivia, I do believe. And so I'm going to look for Renee.
All right, I'm unmuting myself and starting a video so I can see you. I'm Renee Erlinson, and I work for the Office of Public Instruction in the Career and Technical Education Division. I'm the Health Science Education Specialist. So I have a real interest in health equity in that I have the opportunity to share trainings with all of my health science teachers throughout our high schools in Montana. And we have a lot of schools in our health science programs that are also starting to teach students about public health and social determinants of health. And students have lots of questions about why our social determinants of health look so different county to county and when we get into Indian country. I also wear another hat. I work for the Area Health Education Center. That's the Montana Office of Rural Health, Area Health Education Center at Montana State University. And we currently have a series going on right now called Montana Healthy Communities. So heads up to Shane that this is a strengths-based approach of looking at how we can collaborate in many different aspects of our communities to strengthen our communities, not only health-wise, but culturally and all kinds of things. I've been on the American Indian Achievement Task Force at the Office of Public Instruction for the past 5 years, work extensively with our Indian Ed for All folks. We have some really interesting programs going on where we have student leaders in Indian country that really help inform decisions about what we teach. But I'm always looking for new ways that I can share information with my teachers as well as students. So thank you.
Welcome. Thank you.
Awesome. What about Robin?
Good afternoon. This is Robin Souzer. I'm the Emergency Medical Services for Children's Program Manager for DPHHS. And I'm working with emergency medical services and hospital staff, ED, particularly to increase cultural humility, health equity, ACEs. And I'm really excited to hear about the positive childhood experience work coming to Montana. So that's really exciting, and let me know how I can help with that. We have had a grant, and I've worked with 7 cultural liaisons across the state. Cassie Runsabove, for example, is very instrumental in building a cultural of care humility toolkit for EMS. And we have an instructor guide and a student guide. And we finalized that just recently. So I would love to share that and have any insight and input into that as well. So I will try to send that to you, Annie, and Emily, if that's all right.
Oh, that would be so great.
Yeah,
thank
great. Thank you. Excellent. And Rosie?
Hi, everybody. I'm Rosie Ayers, and I'm the coordinator for Project Tomorrow Montana through the United Way of Missoula County. It's a suicide prevention initiative. We're lucky enough to get to work with several people who are in here today, including Tamarack and All Nations. And that's how I heard about it. Faith Price and Ann Douglas hooked us up to get in this course today. So excited to be here. Also, I'm an arts activist and integrated arts teacher for social emotional health as well. And a year ago, last summer of 2019, I got to tour the state of Montana to over 50 cities, bringing suicide prevention through the arts with a play called Every Brilliant Thing. And while I was out there on the road for the entire summer, getting to see all of the public health challenges, it was really deeply impacting to see the disparities and the inequities across Montana. And I learned just a huge amount. And in that, I came back very passionate about wanting to see some changes and some more equity, especially in research and how we even gather information, how we approach public health, what each area needs, and how we are diversifying to be able to bring whatever tools it is we think each area needs, but integrate it more effectively with people who are actually experts in those areas as well. So I'm very delighted to be here with you guys today and to learn from Dr. Annie Belko. Thanks.
Awesome, welcome. And
Well,
now, I was gonna call on Rui. I don't know if I pronounced that right.
It's Ruhia.
Ruhia, okay.
Yes. I'm in a cubicle pod setting, hence the mask. But I should have realized, given what I know about public health so far, that this would have been more interactive, but I didn't know. So next time I'll see about getting a private room or working from home or something. I'm very pleased. I'm a community health improvement specialist working for the Healthy by Design Coalition in Billings, Montana for Yellowstone County. And we work very closely with the public health department here and are kind of responsible for getting the CHNAs done and planning the CHIPs. But I'm very new to this role. I've just been here for a couple weeks, so I'm really in this like sponge phase of just gathering all the information I can, and very glad that I found this work. I'm a certified professional midwife and have a background in midwifery, and kind of as I was like finishing midwifery school and doing some residency work and starting to take on a few of my own clients, I was really asking a lot of these questions about equity and access, and like, you know, feeling like the you know, home birth is like the romantic part that people like to talk about, but really the hallmarks of quality midwifery care, I think, are client autonomy, and that it's really like an intimate relationship that with the patient and the provider, decisions, shared decision making, and that there's quality face time during the prenatal and postpartum care, and that's why we tend to have a lot of good outcomes. But in Montana, Medicaid doesn't cover licensed midwives, and so that choice is really not available to a lot of people. You know, in some ways I was thinking people that arguably would benefit from the most from this like FaceTime heavy prenatal care. And so I was really asking these questions about, you know, I'm a writer and I'm artistic and have done communications and marketing work too. And like, how does, you know, if midwives are serving like less than 1% of the population, how can I be using my intellectual capacity to be serving in a bigger way and actually move the needle in maternity, in mama baby health? And yeah, so when I found this position and started working in this community health improvement role, and very evidence-based, which makes a lot of sense to me. I felt like I kind of found an answer that I had been looking for. And yeah, so my main role here is going to be like the communications service for our coalition, and Billings and Yellowstone County has a significant Native population and others, and I just really want to, I'm just very hungry to learn everything I can right now, and also to try to always be learning more, to be more mindful in, are the communications that I'm putting out there friendly and accessible and approachable to all the people that we want to reach, and not just reach, but like work with, like collaboratively working with the community that we're trying to serve. So yeah.
Awesome. Thank you so much. Is there anybody that I missed? You have a very diverse group, which is wonderful.
Great.
All righty. Okay, back to you, Annie.
Okay. So yeah, I reiterate, you know, I mean, this is, as you can all kind of appreciate, this is a very diverse group, a lot of areas of expertise, a lot of, you know, really thoughtful folks who are doing important work throughout the state and states. Welcome to the Colorado folks. This picture on the slide that you see is actually from Colorado. It's my father, who was the former executive director of the Montana-Wyoming Tribal Leaders Council. So, so the epicenter, so it was one of the things that he helped to create, actually. So he just briefly went to Berkeley and was the first in his family to go to graduate high school and graduate college and go to graduate school. And, you know, and he grew up in Star School, which is a small area north of Browning in the Blackfeet Reservation. And so he's one of the people that, you know, really helped to kind of inspire me to do what I do. And that's him holding my daughter in her little hippie outfit. But like, I really appreciate the fact that so many of you also brought up the idea of resiliency and thinking about how we can build on the strengths of individuals and communities to, you know, create healthier, you know, futures and presents and whatnot. So that's something I just share with you, because I think we all have those same hopes for our children, our families, our friends, and that's sort of, you know, one of the foundational things I think that we'll kind of come back to throughout this, is that, you know, how do we kind of build these strength-based approaches towards intervention and prevention? And so those are some of the things that I'm hopeful that we'll continue to talk about through our workshop. So when we kind of move forward from our introductions, and, you know, again, I really appreciate the depth of knowledge with this group. And I want to also encourage you, throughout that this be an interactive process. So please use the chat. If you'd like to kind of interject, you can. We do have like limited time today, but we will have time for discussion in small groups if things go well. And if not, we will kind of rearrange and have that be next week too. But I wanted to start off with something that is, pretty basic in some ways, but I think it's important. It's a video, and so if you're Zoom fatigued, you feel free to turn off your video for a little bit here. We will come back and have a discussion. But I want to talk a little bit about the idea of implicit bias and health equity. And so this, if it works well, is a video from a colleague who I mentioned is really an expert in this area. And how do we think about deconstructing implicit bias? And so that's what this video is kind of really aimed at looking at. So I thought it would be helpful, and then we'll have a discussion, we'll have a break, and then we'll come back to how this may apply to Montana context. So let me see if this will work. Is this working? Okay, great.
Now I don't hear it. I heard the music. Oh, unmute yourself, Annie, dear. You muted your Zoom mic.
Different terms used, but basically they describe differences in health that are unfair and unjust. There are some differences in health that occur that naturally occur, that would be expected to occur, but it's those differences that are unacceptable because they are unfair and unjust. And I think it's important to me because there are such large and pervasive disparities in health in the United States by place, by socioeconomic status, income, education, occupational status, and by race and ethnicity. And I think it's unacceptable in a country, given the values that we have of providing equal opportunity for all.
Can you personalize that for a minute, a story or an episode or something that gives us a sense of why this hits home?
It hits home for me for many reasons. One is I have spent the better part of 2 decades studying as a researcher these issues. But there are many personal experiences that I have had that brings it home in a very real way. I remember many years ago attending the funeral of a good college friend of mine whose wife, an African-American woman, had just died of breast cancer, and she was 33 years old. And in America, breast cancer typically for most Americans is a postmenopausal condition. And her experience just typifies that of so many African Americans who get a very aggressive type of breast cancer at a very young age. So in the United States, we have this interesting pattern where white women have a higher incidence of more new cases, a higher rate of new cases of breast cancer every year. But under age 40, African Americans have a higher incidence of breast cancer, reflecting the fact that they are much more likely to get the disease when young. I'll tell you a second experience. One has to do with my own mother, who was receiving treatment, and because of poor treatment in a healthcare facility, had a stroke. They had failed. She was receiving her medication through a patch, and a nurse had failed to change the patch. And so she had gone days without her medication and ended up having a stroke, which left her with significant disabilities. So that was another example, because there's research suggests that it's not just her, but minorities receive poorer quality care and less intensive care.
Sorry to hear about your experience.
Well, I don't want to make it a personal thing, although the personal experiences do bring it home, but it does reflect that this is not an isolated case. If we look at national data for the United States, it suggests that just in terms of Black-white death rates, that 265 Black people die every day in America who would not die if there were no racial disparities in mortality in the US.
265 people a day.
265 Black people die prematurely every day who would not die if there were no racial inequities in health.
So, okay, I mean, some of the data are new, but not all of them. We've known about disparities and inequity for a long time. I can remember it from years of my training, decades ago. Why aren't we there yet? What's been in the way?
I would want to first say that we have made progress, and we certainly want to celebrate the progress that has been made. So, for example, the life expectancy gap between Blacks and whites was 8 years in 1950. It's 4 years today. So we've cut it in half. That is definitely progress.
This is for a child born today. The life expectancy gap is shortened by 4 years.
It is shortened, right. So, and that is progress, and we want to celebrate the progress that we've made. On the other hand, a 4-year gap is in fact considerable. And if we look at the average rate at which life expectancy increases, it will take us more than 25 years to close that gap. If we froze the life expectancy of whites and had the life expectancy of Blacks increase at the average at which life expectancy has increased over the last decade. So 4 years is in fact a considerable gap. Why? I would say there are two big reasons in my mind. One is there is not broad-based awareness in the general population and among some policymakers of the magnitude and extent of disparities in health or inequities in health. So that's one reason, is the lack of awareness. If we don't know that a problem exists, we're certainly not going to mobilize to address it. So that's one. The second reason is maybe more troubling and more difficult to deal with. The second reason is there is the absence of political will. I think to make the investments that need to be made in order to make progress. By that I mean that just for many people who are aware of the problem, there isn't an emotional connection to it. There isn't a feeling that this is unacceptable and that we really have to mobilize to do something about it. I'll give you a statement that was made by W.E.B. Du Bois in 1899. This is a long time ago. He wrote a book called The Philadelphia Negro. In that book, he had a chapter on the health of Blacks in Philadelphia in the late 1890s. And he said one of the most difficult social problems in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. And Du Bois went on to say, there have been few other cases in the history of civilized people where human suffering has been viewed with such peculiar indifference. So it's that peculiar indifference, the absence of will to address what is in some ways an unprecedented national tragedy, I think is part of the problem. And so we need to think of ways in which we can tell the story. And I think narrative is important. So I use the word story carefully and deliberately. We need to tell the story of health equity in a way that connects with the American population, because I think we have a very compassionate and generous population, but we need to tell the story in a way that they can connect with and then be mobilized to address it.
Is this racism? Is this racism in society and in healthcare, or is?
Racism is a significant contributor, I think, to it. In multiple ways. Some ways in which the racism is obvious to individuals, and many ways in which the racism is not obvious to individuals. So let me give a couple examples. Back in around 2000, I was invited by the Institute of Medicine to serve on a committee that was going to address the question, what happens when Blacks and other minorities get into healthcare contexts in the United States? Does their race or ethnicity make a difference in terms of the medical care they received. The report by the IOM released in 2003, it was called Unequal Treatment. And what it documented, it was across virtually every class of medical procedures, from the most simple to the most complex. Blacks and other minorities receive poorer quality care and less intensive care. We were not addressing issues of access. The question was, given access to care, is there a difference in the quality of care received? And we found absolutely there was a striking difference. We did not believe, the Institute of Medicine Committee did not believe, I do not now believe that the American physicians wake up in the morning and say, how am I going to get my minority patients today? I truly think that most medical doctors go to work and other healthcare providers and try to do their best for their patients. If that's true, then there's a conundrum here. How is it possible with people with good intentions seeking to do their best can nonetheless, at the aggregate level, create a pattern of care that is so discriminatory? Our answer was implicit bias. It's also called unconscious or unthinking discrimination. And when the IOM concluded that that was a contributor in 2003, there was a lot of circumstantial evidence. Today, the evidence is even stronger than it was then, that implicit bias exists among physicians and other healthcare providers, and that implicit bias affects the quality of care they provide to minority patients.
Can you help us understand a little better this implicit bias use? So I'm a doctor, a patient comes in, white, African-American. What happens in my conscious or unconscious or in the interaction that becomes a generator of the kind of inequity you're talking about?
It's a great question. What the research shows is that most of us, and this is about not white people, this is about human beings, most of us think that we are driven by our conscious cognitive conditions. In fact, a lot of what we do occurs at a level beyond our conscious awareness and is importantly driven by ideas and narratives and stereotypes that have been deeply embedded in us as part of the culture or the society in which we were raised. There's a lot of research that indicates that in American culture, African Americans, for example, are presented as lazy and dangerous and violent. Those are negative characteristics. Healthcare providers are part of the larger society. Research using the implicit association test, which is one test that tries to get at these unconscious implicit biases, finds that over 70% of all Americans have an anti-Black bias. And the number for physicians is also over 70% because they are part of the larger society. We are products of the culture. So it does not reflect then the behavior of bad people. It reflects the behavior of normal Americans who are reflecting the biases and the messages about race that they have received. Importantly, what the research shows is that when we have this negative implicit bias, this negative stereotype, even though we personally are committed to egalitarian principles, without our conscious awareness, when we meet someone who fits that stereotype, we will treat them differently and honestly will be unaware that we did it because there was no intent on our part. And that's why it's called unconscious, unthinking discrimination. It's implicit, it's not explicit. You're not looking at that person and saying, I'm going to discriminate against them. In fact, if I asked you if you did, you'd say I didn't because there was truly no intent. So it's something that we need to raise awareness levels of. There are a number of strategies that can be used to help clinicians and all persons become aware of this tendency that we have. The other point I would say, this is not just about race. Race is very salient. When we meet someone in American society, the research shows, we first put them into social boxes based on age, gender, and race. So race is one of the three big factors, social factors that we focus on. But it is a more general phenomenon if I have implicit biases or negative stereotypes about fat people, about gay people, about old people, about women, those same processes occur. So I like to tell my students that I am a prejudiced person because I am a normal human being. And if we are normal human beings, we are prejudiced because whatever society we were raised in has raised us with negative beliefs about some outgroup. Every society has in-groups and out-groups. So the question just becomes who belongs to an outgroup in the society in which you were raised, which means might be implicit in my own mind.
But you say, is there a remedy if I'm a physician or a nurse and I believe what you're telling me, which is I don't believe I'm racist or acting in such a way, but there are unconscious biases at work. Can I unlearn them? Can I work my way out of it? And if so, how?
There are a number of strategies that have been shown to be effective. One of the basic override, well, I would say two things. The first thing is to realize that that could be me. The typical healthcare provider, I had many talks to medical, nursing, and other health professional groups after the Institute of Medicine report came out. And the typical healthcare provider in the United States would say, I would never do that. I would never provide less pain medication to a Black patient than a white patient. Whereas the evidence is clear that Black patients get less pain medication with similar levels of conditions. So the first thing is to realize that could be me, and that people who have implicit biases are not bad people. They are just reflecting the culture and the beliefs that they were raised with. So that's the first point. The second big principle is the challenge of focusing on what we call individuation versus categorization. What is normal for human beings as we process information is to put things into categories. So I see you, and I don't see you as a unique individual, Don Berwick, but I see you as a middle-aged white male. I've put you in a category, and in my mind, there are lots of associations that comes with middle-aged white male. So it's how do you look at a person, at your patient, at your client, and see that person as an individual, and try to understand the individual context of that person, as opposed to instantly seeing them, which is natural, because that's how we deal with the complex cognitive information we have to manage every day. We put things into categories. It simplifies life. It helps us to navigate our social world. So it's normal for us to do that. So that's one general principle. There are a range of other strategies that have been shown to be effective. One is trying to put yourself in the shoes of the other. So you have a patient who was an elderly Black male, and if you stop and wonder what his life was like, and what was it like for him to grow up in this society, and what are the things he encountered. So the extent to which you try to walk a mile in someone else's shoes, that is another strategy that has been shown to be effective. There's also a strategy that's called counter-stereotyping, which means you think that all women are weak. Well, could you sit back some days and just imagine what a strong woman would look like? Mm-hmm. And imagine that women could be strong. So those are a number, but they're a broad range of psychological strategies that have been shown in very careful laboratory experiments to minimize the occurrence of it. I would say two things. One is processes of implicit bias are more likely to occur when someone is working on the time pressure, so you don't have time to think. You just default to your social categorization processes. It's also more likely to occur when you are dealing with complex cognitive information. In fact, researchers point out that many of the features of a typical encounter between a patient and a healthcare provider, the ingredients within that encounter are some of the very factors that social psychological studies show maximize the processes of implicit biases operating.
I'll guess that fear can play a role.
Yes, fear, anxiety also play a role, absolutely. for anxiety also play a role.
Well, one more question. So let's go back to the 4-year gap between
Yes.
the racial gap in life expectancy that remains
Yes.
and is unconscionable. Can we close that with healthcare, or is it or not?
That's a good question. So healthcare clearly has a part to play, and ensuring that every patient gets high quality care would be a step in that direction, because there are racial, ethnic disparities not only in the onset of disease and the prevalence of disease, but in the course of the disease. The severity and course is worse, and part of the poorer prognosis and the more difficult severity of disease for many minorities, it reflects the fact that they don't get as high quality care. So quality care is important. Most estimates suggest, though, that medical care alone will not solve the problem. We have to look at all of the factors that drive health. The fact that medical care is important in terms of restoring us to good health once we get sick. But what drives health, what makes us healthy in the first place, has a lot to do with the opportunities to be healthy in the places where most Americans spend time, in our homes, in our workplaces, in our schools, in our neighborhoods. And so where we live, learn, work, play, and worship, and the opportunities to be healthy in those places have a lot to do with health. So health strategies would include things like ensuring that every child has a life where they can grow up and thrive and be not only ready for school, but a life free of early childhood adversity and stress, which could include things like chronic poverty, for example, stressors that have long-term negative health consequences. There is a very strong relationship in the United States and elsewhere in the world between education and health. So ensuring good quality academic success ensures better socioeconomic success, which is powerfully linked to health. Looking at the opportunities to be healthy in neighborhoods. In some neighborhoods, it's not easy to find a safe place to exercise. There isn't access to fresh fruits and vegetables. So again, creating a culture of good health where the healthy choice becomes the easy choice, where people work and where people live, are all factors that can play a role in improving the quality of health. And racism has played a role in creating neighborhoods that are unequal in access to resources and so on. So that's another distal mechanism in which racism affects health.
I can't help asking this, so I give you a lamp with a genie installed, and you get 3 wishes that would really close this health equity gap. And you know what? You choose, answer it either from the viewpoint of healthcare delivery, you run a big hospital or a large system, what would you wish for that system, or from larger social perspective, what would be the biggest leverage we could get?
It's a good question. I served on the commission that actually addressed that question.
I know.
And reported that the single biggest thing we could do in the United States is to ensure healthy development of every child. And investing in early childhood, particularly birth through 3. We tend to, when we even think about early childhood, we tend to think of ages 4 and 5. And the processes that shape childhood development and affect health begins earlier. So I think that is certainly one big area, but it's not the only one. I would also say that I think we need to put more health into healthcare. What do I mean by that? Many patients who come into a healthcare context are coming with a range of social challenges that they face. And if all we do is provide them healthcare and not address the problems that made them sick in the first place, and send them back to the same environments that made them sick in the first place, we have delivered good health care, but we haven't had a long-term positive impact. So there are models and there are multiple conversations, multiple examples in the United States of programs that are, as part of the healthcare encounter, linking a client, linking a patient, not only to good medical care, but to social services that might help them address some of the challenges they face. And we know that if we do that, we might keep some of those people from coming back into the healthcare system, back into the emergency room within 30 days, if we can in fact link them with the social service. I think that's one other strategy. And the third thing I would say is strengthening education, which would prepare individuals for successful employment and career advancement is important. Maslow, many years ago, taught us about a hierarchy of needs. And if people's basic needs are not met, they don't worry about the higher order needs. And many of the things that we want individuals to do, to get regular exercise, to not smoke cigarettes. If tobacco is the crutch that helps people make it through the day, and some of my own work and the work of others have shown that smokers have higher levels of stress than psychosocial stressors than non-smokers, and that if you intervene on the stress or underlying depression that they face, you enable them to quit at higher rates. Really? Yes, so again, trying to take in a big picture and trying to address some of the social challenges that individuals face will put them in a position when they can act to make steps to improve their health. Well, Dawn, could you tell me why health equity is important to you and what role you see health equity playing in the context of larger improvements in healthcare?
Health equity is important to me because it's a piece of the larger problem of social justice. I think we have become in the US and many other countries an unjust society, failing to attend to the needs of people who start off with or fall into positions of great disadvantage. And I just don't like that. I don't know why, but maybe because I grew up in a small town where we kind of took care of each other, but no, we can't. I don't want our society to be one in which we turn away. And to me, health equity it's a symptom of the larger crucial issue of the fabric of communities in our society. I guess the other reason is I'm a doctor. I don't practice anymore, but when I did, about maybe half of my patients were under conditions of enormous stress on Medicaid, in poor families and broken homes. And I could see the challenge, and frankly, I felt helpless a lot. That you know, the kid with asthma who came back and back and back because there was no heat in their home, or because we couldn't get the home cleaned, sure. Or the child failing at school who becomes depressed because their self-image is hurt, and then the vicious cycle begins: a poorer sense of self, less effort, more failure, and you could see the cycle penetrated. I could give pills, or I could treat fevers, but that wasn't creating healthy futures, and so it meant a lot to me. There's a case a kid I've written about quite a bit. It's a real story of some patients stick with you, you know. And sure. This young guy, he was a 14-year-old when I met him, was in deep trouble. He was drug addicted. He
at 14.
At 14, he had his first gun when he was 5.
Wow.
And he was in and out of trouble, but then he got leukemia. He got acute lymphoblastic leukemia as a 14-year-old black child, which, as you may know, is an extremely difficult disease. For some reason, acute lymphoblastic leukemia, which you can cure easily in a 5-year-old white, it behaves really badly in a 14-year-old black. But we went to the mat. This kid got everything. We got him a bone marrow transplant, sophisticated chemotherapy, walked him through great difficulties, and he was cured. His leukemia went away at 17. There was no trace, and we remained in close touch until he died at age, I think he was 29, on the streets. He basically fell apart and ended up having a seizure due to drug abuse, and he cured leukemia and killed by poverty.
Yes.
Killed by disparity. I mean, he wouldn't, I've often said he would not have said that. This kid would never, ever blame anyone but himself. It was really interesting. He internalized this, but I say that. And I can't forget that kid.
That is a really powerful story. What advice would you give to people who in their own healthcare system are thinking they would love to start a conversation about health equity and about racial bias in healthcare? What advice would you give them as to how to go about this?
Well, I'm not sure. I mean, maybe call you, but I think that a good rule, IHI's rule in general, is you start with yourself. You don't ask other people to do something you're not doing for yourself. And I think this point you've made so eloquently about becoming self-aware, especially about the unconscious and innate biases that are there that we don't even realize. And I think that introspection, I guess I think it's on the critical path. So if I were head of a large health system, I would say we're going to look first at ourselves and understand this. And I think there are places, people that can help do that, but I think awareness matters, and I think that matters. Another that's very important to me that is part of the principles of quality is the voice of the customer, the voice of the person you're trying to help. And I personally think helping people who are in positions harmed by these latent inequities need to speak and be heard, and not pro forma, not in a focus group, not in a survey, not one at a time, but in mass. And I think if that dialogue is real, and it's starting, by the way, with the Board of Trustees, this belongs in the governance system, where the inquiry is really authentic. My friend and mentor, Paul Batalden, once drew for me a graph of the sequence of events for real change and improvement. And the first box he drew was leadership, curiosity. And I believe that. And I think if we want to reverse this injustice, we need leaders to become, I say, authentically curious. We're not talking about ticking boxes here. It's a real, maybe it's a personal transformation I'm after. That's a big ask. That's a big ask because people are very busy. But I'm a scientist too, and I think then the question, if one is aware and one does care and one has heard, the legitimate question is, well, what might work? What could help here? And I think we need to turn to science. I think we need to understand what's been shown, what might work here, and put it to use.
And there you give one good example of improvement science and a lesson you learned from it. Is there another lesson, any final lesson you might want to give us from improvement science, how it might help address health inequities?
Learn from action. We've been taught, in Western society, and we've been taught you think and think and think and think and then act. No, you think maybe, then you act, because the action produces knowledge on the basis of which improvement can occur. And I really think getting into change is important. That could be one patient, one person at a time, person at a time. Discover an episode of racism at work, an episode of inequity, fix that one, go at it and say, what could we do with this, with this particular person, and learn from that. So I'd say moving quickly as we can to deeds, which then become informative for the future, is much more important than the next strategy meeting.
No, that is great. And I think one of the good things is that there is such a mushrooming body of research on this very topic that is in fact pointing to steps that can be taken. So there's many people are not aware of it, but there is an available science that may not answer every question, but provides the foundation for moving forward in very concrete ways.
I hope so. That will raise the question of measurement and feedback and knowledge. Absolutely. You have to learn as you go. And I guess you would know more than me as to whether we could have or do have the ways, once we do want to have this as a goal, to actually monitor the progress as we make it.
Yes. I sometimes, when I talk about it, says we have a divine solution. And divine, D-E-V-I-N-E, is the name of a psychologist at the University of Wisconsin-Madison who has come up with a model of a number of the strategies, some of which I talked about earlier, that actually work to reduce unconscious bias. And she has shown that she can take non-white individuals and from the community and get them motivated, one, and two, utilizing multiple strategies that followed over time is successful in reducing both explicit and implicit bias.
That's great.
And so there's evidence that and strategies of what can be done.
I've become a fan of Helen Reese's work at
Okay.
Harvard. Helen's interested in, can you teach empathy? Because you were
Yes.
talking
Yes,
earlier
yes.
about walking in someone's shoes. The answer is yes, you
Yes,
can.
yes.
So we're not without some methods and approaches to try out.
We know
where
to start. That's right. So I wanted to see if there kind of was any discussion we want to have around the video. I posed a couple of questions here, and if you'd like, you could respond in the chat, or you can just, chime in and see if there's thoughts that you have. But one question that was early in the video was posed as, the idea of how does this hit home for you? And so that question that's posed to physicians that are working with patients and, public health providers, as well as sort of, this idea of implicit bias, has this been something that you've noticed, that you've seen, that you've, or not, or those kinds of things. So this is one of the reasons that we sent out that test last night, and there's a list of different tests that you can take, and they're not tests per se, but they're kind of surveys to kind of get a sense of how implicit bias may be working within yourselves and whatnot. Totally optional, but it's something that we have used here when we do search committees and things, where we've had people take the implicit bias tests and kind of take a look at, are there things that influence my decisions or that have an impact on how I view applicants or for a job or something like that. And then a couple of the other ideas is that that idea of how do we sort of combat, or how do we address implicit bias? And one of the ideas being the thought of that could be me, or how could I put myself in this person's shoes, counter stereotyping, sort of thinking about that opposite idea if there's a sort of automatic thought that comes to mind. So just wanted to kind of open it up a little bit and have people think about this and have some discussion around this. Does anybody have any initial thoughts or discussion topics?
I guess this is Rahia Tolton from Billings. I guess I just really appreciated that it felt like there was a lot of hope and concrete things. Like I wrote down this list of things that he was saying, that you can do, which I think is, it's not entirely an unfamiliar conversation to me, but or concept, and I've done the implicit bias, like screening tool or whatever, the self-assessment before, but I feel like oftentimes it seems like that's where the conversation ends. And you're kind of left with like, well now what? If I recognize that I live in this racist soup, and so of course it's affected me and how I think, even if I don't realize it, like how, what's next? So that was really great.
Yeah, I really appreciated that as well. I mean, the idea that, we don't just stop at sort of at that level of like, okay, we described, for myself, what my areas maybe I am, a little bit blind to, or what have you, or I have these, thoughts, or biases, what have you. But thinking about, well, how do we undo some of that? I think I appreciate that you brought that up. I think that's an important thing. And I want to look at the work of some of the authors that they mentioned too, that, the idea that empathy is teachable. I think maybe, for some of us, that's something I think we're curious about right now as we're in this pandemic, and we're really concerned about, how do we increase empathy for certain groups? I mean, for our elderly, or for our, groups who are maybe more at risk right now. And so I think that's, a very important thing right now, not to get I've intentionally tried not to talk too much about the pandemic situation, but I do think it's on our minds, right? And but here in Montana, you know, we have, you know, 34% of the mortalities that's being reported are Native Americans, and you know, yet we only make up 7% or so of the state population, and so that's a pretty remarkable thing to think about in terms of how these inequities really can play out in a situation like this where we have a public health emergency. So thinking about, you know, how do we promote equity in real ways, in ways, and I appreciated that about the video as well, because they talk about, you know, how do we improve the built environment, places that are safe to you know, exercise and different things. How do we improve people's access to fresh fruit and vegetables and those sorts of things that are very important. Any other thoughts about the video, or kind of insights or things you want to share?
Well, this is Deshane. I was just, you know, so my undergrad degree is in sociology and my master's was a hybrid between hospital science and medical soc. And I think that, you know, and so Dr. Berwick, just to preface, this is one of my heroes. I think he's awesome. He is like literally the white guy who gets it, the old white guy that you want in the room. You know what and I'm sorry, I can't remember the name of the other gentleman that was in the video.
Oh, David Williams, yeah.
Yeah, Dr. Williams, yeah. And so, you know, what he was talking about is, you know, this unconscious bias is present in everyone. And so just to say, you know, don't be racist, well, a lot of people are gonna say, well, I'm not racist, so that's good. You know, the problem solved. That really doesn't solve the problem. And the approaches to solve the problem of unconscious bias are going to have to be systemic. Racism is systemic. The solution for unconscious bias is going to have to also be systemic. There's a lot of work in sociology about how, you know, you can do that, but I think that we need to look at how the system right now is rigged. Sorry, that was my Outlook. Is rigged. So that honestly, it's not even just white people. It's all people are learning how to do medicine on white people. And so we have, I pulled it up because I'm gonna mispronounce his name, but there was a black medical student, Malone McQuende, who wrote a report called Mind the Gap, where he just looked at, you know, what do skin conditions look like for different colors of skin? Because, you know, he's, as an African person, as African background, his skin is very dark. And then, you know, the skin conditions are gonna look different. And so even if there is a doctor who is, you know, maybe Native, East Indian, Asian, et cetera, they're still in their medical textbooks, they're only learning what does the skin condition look like on white skin. And so it's not even that, because if you ask, obviously, like, you know, that doctor, are you racist? No, they're not. They're like, I'm a person of color. I'm navigating, you know, a system of racism and oppression, but I am not personally racist. But they're still trained from a system that is based on that approach. And so developing these kinds of systemic approaches, like, you know, this mind the gap is a great start. But the idea is that just saying that individual racism is the issue is ignoring about 98% of the problem.
Mm-hmm. Mm-hmm. Yeah, those are very good points. And I think you know, thinking about how that impacts like health ultimately is really a critical piece as well. You know, and you know, I had, you know, come to mind a colleague of mine. So you know, to kind of follow up, you know, we have, you know, as he mentioned in the video, you know, there's age discrimination, gender discrimination, you know, LGBTQ plus discrimination of different ways, and all these different things that are very much a reality. So, you know, in class. So one of the things that I had a professor colleague who shared this with me, and his son had a condition where he like bruised really easily, and he had they brought him to the pediatrician at the time, and when they saw that my colleague was a professor, they were like, oh, well, you know, it's probably nothing, and you know, they were like, but we should probably do some other testing and things. And the point is that had he been not a professor, they probably would have immediately reported it to child services, and because he had these bruises on his body, and ended up he had like this rare condition and things. But my friend was sort of like, the point was, he was like, yeah, you should. You should call Child Protective Service if that's your protocol when a child comes in and has, injuries and things of that nature. Just because I'm a professor, you should not assume that I'm not, so it was a very interesting discussion. It was, and I think it speaks to this idea that how unconscious this process can be, and that how we can kind of project things upon people that may or may not be accurate, and that can really, sway clinical decisions in different ways.
This is Erica here, and I just wanted to say so much yes to everything that Shane just said, and how frustrating it is to think when you look at medical studies and all the medical research, and when you look at how narrow their populations are and how we're expected to extrapolate that to other populations, body sizes, races, ages. I mean, look at the limited research we have with pregnant women, right? Because we don't have that information. So I just wanted to say that. But one thing that caught my eye when from the video was talking about that when clinicians are under stress, or they don't have very much time, it only exacerbates this and only makes it worse because they don't have time to think about it. And I mean, I'm already frustrated at our healthcare system overall, but to think that in our healthcare system, mainstream, it's about making money, it's about seeing as many patients as you can. Providers have like 10 minutes with them. They don't have time to think, so it's just perpetuate. Not saying that is the one thing that we have to change in order to fix this problem, by no means, but just how much that kind of adds to it. Yeah, so that was just something that was on my mind. And then the idea of changing this systemically, more on an organization approach, but like if we had organizations who do value this and are taking steps to doing this, and make it so all of their employees are taking courses on this and continuing education on this and actively practicing it, what would that do? I just a thought as well.
I think those are great points. And I think when you think about it, like to point to clinical trials, that like the kind of the norm is to have, your study population be as like homogeneous as possible, and to kind of rule out different, potential third variables that are causing, what have you. But, the issue with that, of course, is that, is this applicable to other populations when it's only been tested on this very small, homogeneous kind of population? That's been a very serious critique, and I think it's improving, but I think that we need to kind of take those things pretty seriously as we think about it. And like his breast cancer example was a great one to think about, how in different populations these things look different, and they operate differently, and so how we think about those different factors clinically. Yeah, definitely. Any others have any chat questions?
I was just going to add that a piece that stuck out to me was thinking about healthy environments that we're in, where people work, play, and live, and how it's not just on healthcare providers to change the system. We need to help change the underlying environments and social systems that folks are that are impacting their health, and not just the symptoms and different things that they get from those environments. And I think that's important, public health, and we have folks from different areas, and I think about it in my work with college students and how their environments there impact their health.
I think that's an excellent point. I think, when we think about that, even here in Missoula, right, the public health department has done some mapping on like walkability and different factors and income. And when you kind of map those things on each other, it's very quickly becomes apparent, where the low income areas are and inequalities emerge. I frankly live in a place where I can afford, and it's like, we don't have sidewalks in this area. And so it's harder to walk safely. You have to walk in the roads. And this picture that's on the PowerPoint slide is from, you know, near where I grew up. And this is in Browning. There's a little museum, and the statues are from our creation story. And that's my daughter when she was younger. But again, you know, there's, you know, if you go to Browning, that's just not very accessible in terms of walking. There's a big public health issue with, you know, safety issues with dogs. They have recently built a nice walking area to the new high school, which people are beginning to use. And so, you know, that's where some of that kind of hopeful aspects come in, right? Is that these are things that can be improved. We can build sidewalks. We can help improve things, and that's I think one of the things that was you know, underscored within the video, and I appreciate too. Other folks have thoughts or?
Yeah, thanks. I just wanted to say that I really appreciated watching that. I really liked how, is it Dr., let's see, I can't remember his name, but how the gentleman was talking about how it's such a human behavior to categorize people and in order to navigate our world, and that it's, you know, something that is very natural. So I think that helps all of us kind of say, yeah, now I can look inside myself because it is a part of what it means to be human. And I thought that was a really nice way to approach what he was talking about. I really appreciated how he really emphasized that this is a natural and human problem, not just an American problem or an individual problem. So I really thought that was good. And then Emma, I really appreciate you talking back about, you know, that it's more than just the health system. And I think, Annie, you're right. We all are talking about COVID, and there's huge disparity there. And I get frustrated when we don't start looking at some of the underlying issues, which we all know about in public health. We've talked about obesity and diabetes and commercial tobacco, and all of those things also affect people who are the victims of COVID. It's some of those issues that are really making this an inequitable death rate, as if you want to put it that way, in COVID. And I get frustrated when I look at CDC and think about all the things that we're doing for COVID, that we're forgetting to think about how are we going to start getting better food that's affordable to places all throughout our rural communities, and how are we going to subsidize a way to be healthier, or have parents stay home with children from 0 to 3 and have the resources to take care of their children so their children have those protective factors. So what we've seen in COVID is, you know, more people are outside and more people are cooking at home and more people are with their children. These are positives that I feel we're at such a turning point, thinking about health inequity, of making that equitable for everyone, every year, all the time. So that's what, that's just part of what came to me on this, is that we're at a crossroads and we can really, I mean, hopefully have greater conversation. How is our environment affecting our health? How is our food affecting our health? And making it so there's people who are really, who's being most affected by COVID? Not me, living in rural Montana with the beautiful space around me and extra places to get out and working from home. And I'm really fortunate. And many people, and especially many people of color, are not. And that's something that I think we can look at in a bigger way. So that's all.
Yeah, that's really, really right on the point. I think that's, you know, I mean, it's sort of really kind of, you know, thinking about that intersection of like sustained inequality and how that is impacted by when you have something like a public health crisis happen. And that's across the country, not just Montana, of course. You know, I mean, I think that's, you know, it's just become much more visible right now, is that we can see these inequalities and how it impacts these health outcomes and you know, frankly, kind of scary ways right now. Yeah. Thank you. Any other thoughts or discussion points folks may have?
This is Erin.
Oh, go ahead, Erin. Go
Are
ahead,
you
Erin.
sure, Alexis?
Yeah, go for it.
Okay. Well, this is a little, sometimes I'm a verbal processor and sometimes I like to sit on an idea. So I feel like I'm a little in between with this one. But thinking a lot about, I think you said it was Dr. Williams who spoke to why we're not taking action, like why we've seen disparities not be solved, so to speak, over time, and really appreciated this like will, like this desire that doesn't exist with leadership sometimes, oftentimes, and especially with white leaders. And I'm finishing right now the book White Fragility, which I imagine many folks across the country and are reading too right now. And this idea that if we expended less energy trying to prove that we weren't racist and accepted that we all live under a veil of racism and have been taught under that system, and instead put our energy into finding our blind spots and actively enhancing equality, like what a flip that would be. And sitting with that a little bit, and I don't have more to say on it yet, but just I think that's a really poignant part about, for me right now at least, about how to galvanize more action toward this too.
I appreciate that. Thank you. Yeah, I want to read that book. It's on my list here. And Alexis, did you have a?
Yeah, I was just gonna add short. I'll be real brief, but I think too, COVID kind of presents an opportunity for us in public health to really partner and collaborate and build partnerships with other sectors. And you know, it's in times like this and maybe the aftermath where those relationships will really help us address and those in public health, especially addressing health inequity, have those conversations and work on those systemic issues that we see, because it can't just be public health either. We really do need to work with other sectors and other, you know, in government, other agencies to address those social determinants of health. So.
I totally agree. And you know, a nice example of that, I've had some experience working with folks here in Missoula at the Partnership Health Center, and they do a nice wraparound kind of service where they have a sliding fee scale. So they see a lot of folks who are across the income spectrum, you know, from insurance to none and homeless, you know, but they do screening for like behavioral health. They do screenings for, you know, different factors, social health, and is in addition to the, you know, physical and dental and things like that, which I just think it's kind of cool that, you know, they are able to then refer people to, you know, a therapist if they need that, you know, because it was spoken to in the video, we can do all these different things. We can treat the asthma in a way medically, but if we're not looking at the underlying causes, which could be environmental, which could be behavioral, which could be depression, which could be mental health, you know, those things are really critical. And I do think this represents a time where we can start to work across these different, you know, units, as Alexis was describing, you know, and to, you know, long-term kind of shift the way that we view health and healthcare. So, you know, if there's any silver lining, you know, that could be it. But I think these are really important discussions, and we'll continue them for sure. I do want to make sure, mindful of time, that we kind of get through some of our remaining material, but we will have definitely time for questions. You know, we have 2 more sessions for this, and you know, and again, you'll get a link to this video if you'd like to kind of take a look at it again, and you know, and bring it up in discussion as well. But I wanted, if there's no other questions or things like burning questions, like or thoughts, and like move forward, is that okay with folks? Okay. So I mentioned that I wanted to sorry, talk a little bit about Montana. So how we think about disparities and how that impacts health within Montana, how do we think about addressing some of these disparities? What are these disparities? And, you know, given the fact that, you know, all of you are very knowledgeable about these things, I'll kind of go through this relatively quickly because I know that you're probably well aware of some of these different factors, but generally kind of wanted to talk about health here in terms of disparities as well as prevention. A little bit about kind of some of the need for more work in this area that we've already spoken to. And then one example I like to think about is this digital storytelling framework. If we have time, we'll look at an example. If not, we'll look at it next time, so don't worry. And then thinking about future directions. So this is just photos because I like to mix it up on my PowerPoints, but this is one of our sacred areas for the Blackfeet. This is our chief mountain, and this is our area that we, you know, have a lot of spiritual strength that we gain from, and also a lot of people continue to practice traditional medicine and health that Deshane's talked about as well, that help people, you know, sustain and both mentally, physically, spiritually, those, you know, sort of domains that we think about. This will kind of focus some on Native folks today. So we kind of had the video that kind of looked more globally, but thinking about Natives in Montana, since we're the largest minority population in the state. This is just a cartoon I like to show sometimes, but you know, this is something that we experience every day is microaggressions and lateral sort of oppression or violence, is this idea of, you know, how we look on the outside and what that means, and sort of reflects to the video as well, is like how, you know, those perceptions or those kind of assumptions about people can sometimes influence how we think about people. And for many people, you know, the popular imagery or things that are out in the media, you know, are oftentimes inaccurate and offensive. You know, we've seen some of these mascots recently be changed. The story of Pocahontas is one that is a very complex issue for many Native people. And, you know, growing up here and thinking about, you know, the reality of her story is she's this, you know, young teenage girl who was exploited. And yet, you know, we have this sort of popular imagery of this like glamorous, you know, mini-skirted, you know, sort of image of, this is something my older daughters face a lot, is the idea of like, you know, being exotic or what have you, or being, you know, or vice versa, like being followed in stores or things of that nature. So things that, you know, that we know from the literature have an impact on not only the sort of emotional, psychological health of folks, but also the physical health over time. We know that these things kind of accumulate over time. So we're going to talk about some health statistics, but, you know, remember that this is not something that is a fact for every person, you know, in every given community. Native people here in Montana do tend to face more of these things and these challenges, but, you know, again, we have, you know, many examples here in this group of people who have overcome such a great deal of things to accomplish things that are, you know, pretty remarkable, like Deshane and Faith and, you know, Laura and everybody who's on the call, you know, so just, you know, keep that in mind. I like to kind of mention that, you know, we're definitely kind of working from a place of strength-based knowledge. So when we think about health disparities, and all of you sure are aware, just, you know, differences in incidence, prevalence, mortality, or the burden of a disease. And it differs by these different variables, right? Gender, age, socioeconomics, ethnicity, culture, sexual orientation, disability is something that is not often spoken to, but very important, special healthcare needs. And then we think about the social determinants of health. We think about poverty. We think about historical trauma exposure for many populations, not just Natives, social disadvantage or discrimination, systemic problems within education or health, or different factors in environmental health, which I'm really appreciative has come up today quite a bit. We think about environmental factors, and that really differentially impacts populations and peoples of color. And then of course, family history as well. So the Native population in a nutshell is increasing. Part of that is because of the census, which if you haven't finished your census, please finish your census. It is allowing for multiracial reporting. So you can say, I'm Native American, I'm African American as well on that. And so we saw this big change in the 2010 census. When we think about the IHS, I'll briefly talk about it, but it's one of the primary healthcare providers for Native people in the United States. And, they serve Natives in both rural and urban areas. And 78% of the Native population live in urban areas in the nation. But we think about Montana, it's actually nearly the opposite, with the majority of Native people living in rural reservation communities here in the state. A lot of people live in urban areas, as Deshane and others can attest to, but we do have a little bit, different kind of reality here within Montana, but what we see commonalities within all of our Native populations with regard to health and some of the risk factors that we see. Young population, we see, for many of you know this, but just significant diversity. When we talk about tribal communities, there's over 570 federally recognized tribes. And within that, there's just significant diversity with regard to our histories, our political structures, languages, economic factors, familial lifeways, kinship, and then also historical trauma and historical resilience. So different factors that have led to different health outcomes for different populations. So we think about that with regard to, poverty, can be different for different tribal communities, housing shortages or inadequacies. So inadequacies meaning a lack of running water. That's really come through right now with the pandemic that we've seen, like Navajo in particular, showing that, a large percentage of their population lack access to clean drinking water or water, period. So, they can't really abide by the hand washing guidelines when they don't have that access. Also dropout rates in terms of education and disparities in that way. So we see that here in Montana. And, we have somebody from OPI who can speak to that, in terms of some of the inequalities there. We also, of course, have people who've become like professors like me and, attorneys and, many, physicians and different aspects. So it's the whole spectrum that we're talking about when we talk about Native people, as well as other populations as well. This is just interesting in terms of like the kind of ways that we're seeing changes. So Blackfeet here in Montana actually had the highest proportion of multiracial or multi-tribal individuals reported in the nation. Yupik in Alaska had the majority of members who solely identified as Yupik, and the Navajo Nation had the highest who were self-identified as Native. So they have a very large reservation that you may have learned more about within the media and things. Cherokee had 65% of the population report multiple racial categories, but they also have a different enrollment criteria. And I don't want to get too far into that, but different tribes have different enrollment criteria that they are allowed to kind of say who can be members or not. And some of that is based on what they call blood quantum, which is really a very antiquated system of looking at, and Faith's father, George, has many lectures about this, so I don't want to like too much nutshell this, but looking at, based on eugenics really, and like how we look at how racial classification and things. So it's very, very old, like outdated way of viewing people. So we have to have like cards that show our blood quantum, and you have to document that to be enrolled. So it's a very strange, really the only population who has to do that within the United States. And part of that is because we do qualify for different different aspects in terms of group tribal sovereignty and different aspects of that. But the trend overall is that we have multiple tribal affiliations for most people. So we're, increasing population as well. So service provision. So this is something that sometimes people kind of get confused on, and that's totally, understandable because it is a bit of a quagmire to a degree. But tribes obtain healthcare for their members through treaties with the federal government, and that can be for a number of different things. It can be for direct services, and that's like through something like a hospital. We have 2 direct service hospitals in the state, one in Browning and the other in Crow Agency. Could be through contractual or compacts. So tribes have, through the Self-Determination Act, can choose to receive healthcare directly from the IHS or contract to control over administration and funding. So that's called self-determination contracts, or I think, we're forgetting the name, but an example of that would be the Confederated Salish and Kootenai tribes have a self-determination contract where they provide their own healthcare services through that contractual agreement. And then also compact. So, and that's where IHS assumed control over healthcare programs that the other IHS would otherwise provide, which is, so, and there's other aspects. So for example, sometimes they'll have to contract with places outside of the IHS, and funding becomes an issue, which we'll come back to. But in theory, self-governance is really supposed to help tribes have the most flexibility to take healthcare services and the needs of their communities into consideration in their decision making. So the Indian Health Service has, and this may be a little outdated, but they have services provided through 33 hospitals in the nation, 49 health centers, 46 health stations. There's 100 different Alaska Village clinics and 34 urban Indian projects. And Deshane, I'm sorry if this is inaccurate, you can help. And
There's
then
41 now.
okay, thank you. I knew he would know. And then epidemiology centers, which I think there's 7, or I think there's more than that now as well. So these are some of the ways that IHS is kind of working to help, improve health within tribal populations. So I will say there's a very big difference between these different facilities. I've been to, of course I had my primary healthcare was Blackfeet Community Hospital for most half of my life. And then I recently was able to go to Alaska and see some of their health services, and it's pretty amazing. I mean, they have like a multi-million-dollar facility. I think the artwork alone in the building was about $1 million worth of artwork. So very different than the hospitals that you'll see here, and a lot more resources and different things. Similarly, like Phoenix has what they call their flagship medical center, and it's very well equipped. And my sister worked as a nurse there for a number of years. So a lot of variability in terms of quality as well as services that are available. So this is the Billings area for IHS. So it includes both Montana and Wyoming, and you can see the different. Hopefully it's not too small, but here we are in Missoula, Flathead Indian Reservation, the Blackfeet, Fort Peck, Fort Belknap, Rocky Boy, Northern Cheyenne and Crow, and then the Wind River Reservation. So represents a lot of geographic diversity, as well as cultural diversity for tribal communities. These are some older pictures, but some photos. This is an old photo of the Blackfeet Community Hospital and the Crow Agency Hospital, which flooded a few years back, and they were able to do some repairs on that. But and I think this is an old photo of the Mission or St. Ignatius Clinic, and I believe this is Fort Belknap. I always forget which clinic this is, but you can see fairly small facilities. So again, Around 7% of our population is American Indian. These are some of the tribal nations in Montana. And, you know, some of these are the anglicized words for tribal communities. Most Native communities prefer to have their own tribal language name for themselves. But this is just, you know, things that you have probably, you know, heard of. So, and these are some of the, and again, you'll get a copy of this. I am kind of whizzing through, but you'll get a copy of the PowerPoint. We have 7 reservations and multiple urban centers here in Montana. And then we think about, this comes from a report that came out of the MSU Extension Office. And they looked at poverty and looked at how this translated to the state. And overall, the poverty rate was about 14.1, and this is older data, but it's pretty consistent. Montana had the 17th highest poverty rate at that time. And the counties with the highest poverty rates included Roosevelt, Glacier, and Bighorn. So if you can see the map, you know, where do you think that that corresponds with in terms of the counties?
The Indian reservations.
Yes, yes, yes.
Or Blackfeet, and Bighorn is Crow.
That's right. Yes, and so you see the next slide here, we have you know, a graph that kind of compares some of these different rates based on the actual reservations. Although we have limited data about Little Shell. So here's the so Blackfeet, Crow, and the thing to kind of look at in terms of comparison is this bottom row where Montana and these different rates are compared to each reservation community. And you can see overall, all of the reservations kind of averaged out for poverty rate and unemployment rate. So it's a pretty stark difference. If you look at, you know, in no reservation is it, you know, I mean, the only one is like sort of nearing that is Flathead, that of the overall state rates in these different areas. But part of that is also keeping in mind the Confederated Salish and Kootenai tribal reservation is very checkerboarded, more so than any of the other reservations. And so you have a lot of non-natives who came in and historically bought more of the agriculturally rich and, you know, areas of the reservation. So there's a lot of non-native owned land on that reservation. So, and more population as well. So if you've been to, you know, Polson and went to the lake up there, and you know, there's just, you can see there's a lot of non-natives who have, you know, kind of moved in and bought properties and things of that nature. So kind of skews their data a little bit. But the takeaway is that when you start to kind of dig a little deeper, there's really pretty stark differences between our tribal communities and that of other Montanans. So when we think about health disparities, we think about, you know, these, what we've called social determinants of health, education, poverty, socioeconomic issues, and racism as well. But we think about some of the inequalities for Native people. You know, diabetes is one, childhood obesity, dental caries, as well as adult mental health issues. And I've done some work in the mental health domain, especially, and PTSD, depression, and substance use are the 3 kind of top things that we see as being issues from the research that has been done. And then, of course, access to care. So this is just kind of like following up with the video when we think about health disparities here and life expectancy. So for Native people living in Montana, it's about 67.2 compared to, and these are a little bit older data again, but the national average and even Native Americans throughout the nation. So Montana has some unique risk factors here. And below is some of the data from like Burfus, where they kind of showed some of the data from women living in Montana and some of the factors. But actually, when you look at it in terms of gender, men are definitely living shorter lives, and that's kind of what's driving that average in terms of the life expectancy. So it's important to kind of recognize that fact. This is just national data, but when we think about like the 5 leading causes, most of these are the same as other populations. So diseases of the heart, cancer, unintentional injuries is different for natives. We see type 2 diabetes, liver disease, which also is different for natives, and then cerebrovascular or stroke in women. And this is just a comparison from IHS data that talks about these different factors compared to US overall. So you know, these are some of the factors that we think about. And this often surprises, like when I talk about this with students, like tuberculosis is still, you know, a problem within communities. But again, if you have lack of access to clean running water, sanitation facilities and different things, that this can, you know, become a problem. Trauma, so a number of you have mentioned trauma. Child maltreatment as well as violence against women has been a big issue that we've been seeing more, you know, coverage in terms of media, and also thinking about how we can, you know, prevent some of these things with the missing and murdered Indigenous women. You know, we've seen a lot of more activism as well as information that has been, you know, shared about this. But the fact is just, you know, Native Americans do experience trauma more frequently. That trauma tends to be more, you know, severe in terms of the scope of it. And that's, you know, a problem. And as Deshane and others have pointed out, you know, with adverse childhood experiences being something that we think about. And I'll be talking about that a little more next week when we talk about some of the issues with regard to child development and how that relates to some of the issues of culture and some of the issues that we're talking about. Not specific to culture, but specific to, you know, when we think about the long-term development of children. Suicide, so a number of you specialize in this area, but Montana sort of, you know, at the time that I wrote this was, had the highest rate in the United States. I think we've kind of come down a bit, so which is good news. But American Indians have, among that, the highest rate of suicide. And this has been consistent for many years, unfortunately, that American Indians have one of the highest rates of suicide within the nation. It's mostly within our youth, within ages 14 to 24, males in particular, who have a higher rate of that problem. But it's also an issue with non-natives and whites who are living in rural Montana. And we see, you know, a lot of prevention efforts here at the state level and local level, but it's still something that we're seeing as a big problem. And there's many potential reasons for that, but you know, something that there's some great resources that we can point you towards. But there's some you know, great website, you know, montana.gov, that has a lot of good data about this as well. So as I mentioned, it's a problem that really impacts Native youth, which is different for other populations. And in other populations, you see this more among elderly individuals. But this is a bit of an older example. But you know, there was one, just a period of a few months, that one reservation had 7 completed suicides. And you know, it's important to kind of think about that in terms of how it impacts the whole community, because there is such a kind of rural, kind of tight-knit nature to many of our reservation communities, that, you know, people know each other. And so when it impacts one family, it tends to kind of have this ripple effect, and sometimes have a contagion effect, which we've you know, heard about within public health. So a lot of need for community-based interventions there. And I'm really glad to hear of the work that people are doing to help within that. I'll show a video that kind of shows, there's the warrior movement that folks have been involved with, you know, to do peer prevention work, which has been really powerful. these are some of the kind of risk factors we think about generally for different issues, but at the individual level, gender can be different, especially with regard to suicide, but also some of the mental health issues and physical health issues, substance use, mental health problems. And then at the familial and peer level, we think about family and social stressors, family history of suicide or of different health conditions, and abuse. And then society level factors, we think about those social determinants of health. These are some of the funding disparities I mentioned. You know, again, a little bit older data, but we think about this, that this came from a publication from the former director of the Indian Health Service. And they found at the time that there was estimated that we spent at the federal level twice as much to help federal prisoners receive health care than American Indian patients. So really, you know, pretty disparate, and you can compare that to the VA population or to federal employees, and we, you know, see that even, you know, more of a difference there. And of the budget for the Indian Health Service, only 7% at the time was allocated to mental health and substance abuse services. At the time, there were only 2 psychiatrists employed, and this was like from, I don't know, maybe 10 years ago, so it's not like in the ancient past or anything like that. And there were only 4 psychologists per 100,000 patients. So as an example, well, there's a video, if you'd like to look up, it's called Don't Get Sick After June, and it talks about funding and some of these different issues within the Indian Health Service. But I know for my colleagues in Blackfeet that they've said that the wait time can be up to 3 months to be seen by a behavioral health specialist. So just kind of summarizing what we've talked about, risk factors, we talk about these different things. We'll talk more about some of these different things, but also importantly, resiliency factors. And this is where I really kind of want to, you know, highlight some of the work that's happening now in terms of, you know, looking at cultural factors and how culture can really be a protective factor for families and individuals. Extended family as well, access to healthcare, access to early intervention. We have early Head Start within many of our communities, and then healthy families and how that can be a protective factor. So I kind of wanted to shift, and I'm going quickly because I'm trying to make sure we have some time to do our breakout session. But one of the things I've been looking at is digital storytelling. So this is just an example to kind of have you thinking about this next section where you'll break out into small groups. Digital storytelling is something that's not super complicated, but it's just helping people use tools to tell their own stories. And it's a way to share like stories that can be public health based, that are from their own lives, community, peers, and family. And it's a really cool way of combining spoken word as far as a basis of the story, but then also non-copyright images and music. And the goal is to produce like a short personal multimedia work. So this is by no means the only tool in the public health toolbox, but it's something that I think can be a nice way to engage youth. It can be a really cool way to have even elders and others participate. And then it can be shared in different ways. We've had a number of different workshops where we've taught people how to do some of these digital stories. And they've been shared at like powwows, and they've been shared at different gatherings or just through social media. And people have really found them to be meaningful. So this has been a kind of cool thing. Just kind of want to kind of go through some of these like protective factors when we think about any population, but natives as well. You know, having strong beliefs about the meaning and value of life, life skills, which can be many different domains, economic to just behavioral, like daily living skills, healthcare we've talked about, having friends, you know, really protective. And it's a scary thing right now with all of us being in isolation, is maintaining those social ties. Religious and spiritual beliefs. For suicide in particular, having a fear, a healthy fear of risky behavior or pain is helpful. hope for the future, sobriety, strong sense of self-worth, and personal control, having bonds with others that, you know, can be mentors or family members, being able to participate in community activities or school activities, having a, you know, reasonably safe, stable environment, and difficult access to lethal means is for suicide in particular, but then also responsibilities and duties to others. And for many people, pets, you know, that's a big thing that can be a really protective factor where you're caring for somebody and you're also, you know, receiving benefit from them as well. So resiliency is something that I'm really passionate about, but, you know, this is just a quote. So I, as an undergrad, also did a lot of creative writing. So, you know, one of my favorite authors is N. Scott Momaday. And so this is just kind of speaking to that within a Native context, but it could totally apply to other, you know, populations, of course. But it's that idea that you're, you know, facing a challenge, you're facing, you know, pain really in some way, and being able to kind of, you know, go beyond that and to challenge yourself to work through that pain and to kind of continue on. So this is something that I think we see within a lot of our Native communities, is people are really working hard to try to improve life for their families, but also for themselves. And often, you know, it's, let's face it, it's a very stacked deck, you know, for many communities, especially when you consider that, you know, we were segregated to reservation communities and had a lot of historical trauma, racism, different factors that people have faced. Okay, so I think we have time briefly to watch an example, and then we're going to kind of move into doing a quick breakout session. So let's see how this works. The audio is a little funky on this, so hopefully it'll be okay.
Native women have always been the strengths of our communities. Montana is home to 12 tribal nations. As Native communities, we all have diverse histories, creation stories, cultures, and languages. We also share areas of common ground. These strengths include courage, generosity, and wisdom.
As Native people, we share how much we value our families. As Natives, we are brought up to care for each other, for our families, for our communities, and for our children. Our children are the most important part of our lives. We work every day to help provide for our families, educate our children, protect our elders, protect our youth, and to promote healthy and happy communities.
As Native women, we sometimes forget to take care of ourselves and our own health. Sometimes the most important thing we can do to take care of our families is to take care of ourselves.
Cancer is a topic most of us do not want to think about. Native women have the worst cancer survival rates. Compared to non-natives, 70% of natives diagnosed are more likely to die. This is likely due to late diagnosis. This is because we wait too long to be screened and treated. We realize that breast and cervical cancer is a taboo topic to discuss, but we have to find a way to prevent and reduce cancer by talking about it.
The best way to prevent cancer is early screening, early treatment, and routine or regular medical care. However, Native women are less likely to be screened and treated early for cancer than non-Native women. Problems identified by Native patients is a lack of access to screening, but also the need for more culturally sensitive and appropriate services.
As Native women, we face many barriers to breast and cervical cancer screening. The biggest barrier is fear. Traditionally, we have come from a history of warrior women. We are women who value bravery, strength, and courage. We must continue to be brave so we can take ownership of our health and take care of our families.
In response to the need for cancer prevention, a group of Native women have come together in partnership
with the Susan G. Komen Foundation to share knowledge, consider the risk factors, understand barriers to screening, and explore cultural barriers to cancer prevention within Indian country.
We realize the urgency of ending cancer. Together, we can remember our strengths as Native women and as Native communities. Women are the keepers of our Native families. Men can help promote the message of early cancer screening and help prevent breast and cervical cancer. As communities, we can teach our children the importance of cancer prevention.
Together, we can reduce breast and cervical cancer. We can do this for our families, for our children, for our grandchildren, and for future generations.
Be brave, be screened.
Be brave, be screened.
Be brave, be screened.
Be brave, be screened.
Okay, so let me see where I am. So, you know, we've got some critiques from this video because like you can't prevent cancer per se, but, you know, but the idea is that you're engaging communities in this idea of health promotion. And so, you know, these are community members who wrote the script and did all of the work to get, you know, the images and everything. And we helped edit and everything, but the idea is that we're having people, you know, tell their own story. So the next couple of workshops, I'll share a few more digital story examples, just because I think they're, you know, they're interesting and it might spur some ideas as you move forward. Sorry, get back to where I can advance my slides. Okay, so small group discussion. So what I'd like you to do is Emily and her wonderful tech knowledge will help us to divide into small groups, and those will be in little breakout discussion rooms, and then we'll come back after that. And so given the time, it is about, so we're just going to do this quickly, really is like, you know, 10 minutes, but brainstorm 5 ideas to help reduce implicit bias and improve health equity in Montana. So are there ways that could engage communities or individuals in innovative ways and new ways and, you know, kind of cool ways that would like get people to kind of think about these things in a resiliency based or prevention way? And what would that look like? So not thinking of cost or anything like that, but what would that look like? And just 5 simple ideas. You don't have to kind of, you know, we're not out to like solve the world's problems, but try to just get some ideas cooking here. So does that sound okay to folks? Okay, so with Emily's help.
All right, you should all have a little invite to go into a room. You've been randomly selected with people. So hop on in. Welcome back.
Welcome back.
We missed you. Okay, so that should be everybody.
Okay, great. Welcome back. So thank you for participating in this. I wanted to kind of just do a quick kind of report back. So maybe if one volunteer from each group could like provide what are the 5 ideas you created and how would those ideas help you reach your goals and what would it take to make it happen? And if you don't have all those, it's okay, because we only have a few more minutes, and then I'll let you all go for the afternoon. Do we have a volunteer for group 1 or?
We can just pick names. I'm gonna pick on Amanda.
Okay, I'll go. I mostly didn't want to go because I feel like I'm not going to give this justice because Deshane talked about this super well, and I don't know Montana very well, so I felt weird answering this
question.
Fair point. But I think a lot of what we discussed was really embracing like the culture and the community and really sharing about the people and looking at the positive aspects of like who the people are, to be able to reduce implicit bias and like letting people actually understand who people are. For me, I was saying like really sharing community voice. That was kind of where my idea was going. And I think to make the ideas happen and to reach these goals, it would be great if there were not restrictions on money and like what people in higher up levels tell you what you can and can't do. But we don't live in a perfect world. So please, if anybody has anything to add, let me know, because I don't feel I did that justice.
Well, I would just quickly add too that, you know, so the idea was people are constantly exposed to, at least here in Montana, to negative stereotypes around American Indians. So the idea was to, you know, actually highlight some of the community strengths, cultural strengths, et cetera. But then also that this is a two-way street, because Indians don't trust healthcare systems. They don't, and they have a reason for that. And there are healthcare systems that are trying to do some really good work. So there also needs to be some PR on their end on making them seem like a viable resource, because right now they don't. And so putting money into, you know, getting non-natives to see the strengths and assets of Native individuals and community, and getting natives to see the strengths and assets of non-native healthcare institutions.
Excellent, yeah. Those are great ideas. Yeah, one cool thing I saw once was some university in Nebraska or somewhere was they did like playing cards, but on the like they had like Native healthcare heroes. So they had little profiles of different like doctors or nurses or things like that who are working in Native health, and it's kind of a cool thing. I'd never seen anything like that before. So some creative ideas to get that positive messaging out, for sure. Great, thank you.
Who else we got from the other groups? Can I call on Leanne? No.
But you can. Anyway, so we just talked about, you know, we just kind of talked about promoting education and how addressing people, having maybe like younger people address younger people, and just how not everybody embraces the same type of person. So, and then also about giving out rewards maybe for healthy behavior, and, you know, making that, you know, instead of just telling people what to do, making them part of it. And if they had taken all their steps or ate healthy, or they could enter into something to get a reward back. Not, you know, exactly sure what that would be, money, or it could be anything, but that.
That's a great idea. I know they do something called Booby Bingo for like breast cancer awareness in Menifee reservations, where they do bingo games and then people get prizes and things like that. And they, you know, they kind of, but I like the idea of incentivizing like, you know, healthy behaviors. It's really a cool idea.
We also, and I was in Leanne's group too, but talking about those proactive factors rather than always the negative, doing that. But Leanne was also talking about that with in their immunizations and in their new clinic, really, how do you get people to your clinic? I find that, you know, transportation, especially in our rural areas, and especially with people with poverty where a car doesn't work or they don't have gas money. And really, how are we making transportation to and from a health clinic important? And I know in the work that's being done, especially Deshane, you can probably back me on this. I know Dan has talked a lot that there at the All Nations Health Center, you have to almost go pick everybody up to be a part of the great programs that you have, because they don't always come for many reasons. So I think transportation is a really important piece as well.
It's a great point.
Well, Annie, we've only got about 3 minutes.
Okay. So you can drop, if you didn't get a chance to respond, you can drop things in the chat, because we're going to be able to share that with everybody after the presentation. So I apologize, we're running short on time for those of you who haven't been able to share, but this has been really a great afternoon, and I really appreciate all of the thoughtfulness that has gone into this discussion. In the last couple minutes that we do have, I wanted to share with you the homework assignment, or I have to reframe it as like the learning opportunity, which is a way one of my graduate school professors talked about things. But really, I don't want this to be like a taxing thing, but just over the next week before our next session, 1 hour, you can use Google Scholar or any other kind of like search engine, or you can look at the CDC or montana.gov or any kind of resource that you'd like to use, and just look at maybe one health disparity or equity issue that is of particular interest to you, and make one PowerPoint slide. That's it. Just one PowerPoint slide that briefly summarizes the main findings. And then mention on that slide, how does culture influence the factors that you reviewed? And then how could public health practices be informed by this information? So kind of thinking about that tool development, skill development aspect. So really don't want you to spend a huge amount of time on this, but I'd like you to just to have that. And then what we'll do when we check in next week is we'll share those slides, and we'll talk about that, and we'll kind of brainstorm some ideas about how we might be able to turn those ideas and those information, that summary, into some tools that could be used. Does that sound okay? Okay. And we're going to send the PowerPoint to you, and we'll send the chat information. Somebody had a question about podcasts. I have a few different ideas I can send a link to. Those are some really great resources. And I think that's it. Does anybody have any questions before we go? Not that I left a lot of time, but I really appreciate the fact that you've all been really just, discussing this and jumping in throughout the afternoon. That's been the goal, is that we have this not just be me talking, but really having us all have a discussion about this, because these are not easy questions and they're not easy topics. And so the more that we can kind of have different perspectives, sort of work on this different ideas, to me is super valuable. And I really appreciate each of you and the contributions that you've been able to make today, and that you will moving forward. So thank you.
Thank you, everybody. I will be sending emails out with this information, and then I'll poke at you next week and remind you of your learning opportunity that you were supposed to do. And might collect those ahead of time if we can. That might make it a little smoother. If you don't hear from me, please let me know. No matter what, every one of these, sometimes your government addresses bounce back and you don't get the information. So I'm sending it to everyone that's here, but if you don't hear from me, I'm putting my email in the chat right now. Please make a quick note of it, and if you don't hear from us, holler, because we want you to have the info.
And also questions, or if you have also requests for information that you'd like me to cover, please also send that, and I'm happy to incorporate that.
Thank you.
Great.
Thanks everyone. See you next week.
You guys.
Thank you.
Thank you.